Good afternoon, everybody. Hello from Los Robles Hospital, and I would like to thank the organizers of MedStream for allowing us to participate. We have a very nice team over here. On my right side is the cooperator, Professor Greg Fontana, cardiac surgery, Mike Limon, John, who cleans the floors but also helps in helping the cases too, Carl, Sue, let's say Marwa. She's one of the first-year cardiology fellows. She wants to do the procedure live, right? On the anesthesia is Valerie Walker, and Laylee's also one of the cardiology fellows, and you have two other residents there too. And in the control room is Gabe Oreda and Kristen Clark. And Kathy, and where's Kathy? Kathy over there sitting down quietly. Kathy, and where's Sophia? She's somewhere around over here. And then Diane's doing nothing over there in the corner. So we have before we show what we've done, let's actually show the case, and then Greg will ask you a comment.
Sure.
So next slide, please. This is just our heart team, which is, you can go to the previous slide, please, for a second. I just like to show the heart team because we have a group of physicians, cardiologists, surgeons, echocardiographers, and anesthesia who help out. I want to give special recognition to the physician assistants and the valve coordinators and all the staff of the cath lab. Thank you very much. Next slide, please. This is a 89-year-old lady who I know for many years because she came and underwent a triclip procedure in 2018, and when she had only moderate AS and a primary symptom. And she did quite well, and actually Valerie's going to show you some pictures. She had a permanent AFib, and she also had a Watchman procedure. And then progressively over time, her aortic stenosis has got worse, and she's becoming symptomatic, and her mean gradient is around 30, and a peak grade and a valve rate is calculated at 0.54. She's got moderate pulmonary hypertension, and based on her frailty, her age, she was considered to be high risk for open heart surgery, so she was considered for TAVR. So I'll show you some of the CTs, and let's go to the next slide. So that's the transthoracic echo. You can see that it's a trileaflet valve, which is heavily calcified. You agree with it, Greg? And the mean gradient, I can't read from here, but this is, I think it's running around 30 millimeters of mercury. And the DVI is clearly less than 0.25, and the valve rate is coming to around 0.6. So it was severe AS, no doubt. And Valerie's going to show you the same pictures. Next slide, please. And this is the CT analysis. And the CT analysis shows how much I think it's the perimeter is coming to about 70. Am I correct? Correct. Yeah, the perimeter is 70. The next slide shows the coronary heights are adequate, above 12 millimeters on each side. There's no sinotubular junction calcification. There's some LVOT calcification only. And next slide. And this shows our arteries, and arteries are borderline actually. The femoral artery is only 5.5 average, so between 4 and 5.6. There's not much of calcification, but the arteries are not very large. So, Greg, what's your comment on this case?
Yeah, I think she's a classic high risk to extreme risk patient who's got acceptable anatomy for TAVR. Sizing is appropriate. She does have a concentric calcification in her distal aorta, and I think being an advantage here is to having an inline sheath where we're going to not take up too much real estate, and we've already placed our pigtail path, so there won't be so much interaction. So I think it's good. The only question, Saibal, is there was very heavy calcification, even though the gradient's not super high, whether or not we should consider pre-dilating.
Yeah, so I think what we should do, Greg, is do you agree that we should go in and if we find the gradient to be 35, 40, I mean, I'm happy to pre-dilate if you think so.
Well, normally we look at high gradient, heavy calcium, bicuspid, and horizontal as our kind of our.
Valerie, do you want to show some pictures in the
let's look at the T and see what she's got.
Laylee, do you want to show? Yes. So you can show, that's the Watchman device, you can see.
Oh, the Watchman.
Can you show echo large now? Pedro, can you show echo large? Yes, so that's the Watchman device, which was placed in 18. There's no thrombus.
Optimally,
and that's a Watchman 2.5. That's the aortic valve. We did general anesthesia because of her age and frailty. You agree with it, Valerie? Is that why you did full anesthesia?
Valerie?
Yeah, I would say that her age and her multiple lesions, the valvular lesions, puts her in a higher risk category for sure. And the sedation, the question of general versus sedation comes up. We do try to minimize the exposure to anesthesia, but in her case, the safest thing is to just do general anesthesia.
So that's a good point. I mean, this is something for teaching's sake that all cases should not be done under more conscious sedation. And I think we, as a group, choose based on the patient whether he should be general anesthesia or not, right?
Absolutely.
All right. So, Valerie, you want to just show a bit of the aortic valve,
Sure.
and then we'll go show some parts, and then at the end, I'd like you to show the tricuspid clip. Okay.
Okay,
So
sure.
let's show that now.
So here's a nice picture of the aortic valve. There is a significant amount of regurgitation as well as stenosis. You can see from the turbulence through the valve. I went ahead and measured the valve area just quickly with the continuity equation. I came up with something similar, what she had pre-op was 0.7 centimeters squared, and I'm getting around 0.8, so that's consistent. It's also
What sort of gradient did you calculate?
let me go back to that.
Carl?
So her symptoms.
If we need to balloon, what do we select?
Let's see. I think I did, her pre-op gradient was a mean of 30.
That's okay. You don't have to, Valerie, please don't do it. It's okay. Don't worry about it. So just show us the 2D, explain that. Yeah, that's
Sure.
right. Let's show that. Yeah, that's actually quite sure. It's a nice picture to show the 3 valves, right?
Here's our short axis view of
Right.
the valve.
Yeah. So it is moderately calcified at least. And there's AS and AI, right? All right.
Under anesthesia, her gradient was a little bit lower, it was like 28, but
Yeah.
that's
I wouldn't
pretty
be surprised. Yeah.
consistent. Yeah.
So I think there's no question about the severity of AS in this patient. Now the question is, in the meantime, I've done some things. Can you start showing fluoro and the patient? So we got left arterial access, and we got 7 French sheath. We have a 6 French pacing wire. Interestingly, as you will see in fluoro, because of the tricuspid clip, we had some challenges to put the pacing wire across the tricuspid. But what we got is we got it in the coronary sinus, and he's actually pacing quite well in the coronary sinus. So I think we should keep it there.
Yep.
So that's actually interesting. We use the right radial artery for Sentinel, and we've decided to use a 26 valve based on an Evolut, based on the perimeter, which is 70, so somewhere between 63 and 73. But we are using a Sentinel, and we had just started doing the Sentinel when we came in. So I would like to see fluoro. So we've advanced the wire, proximal into the left carotid. I'm advancing the wire there. And now I'm just going to pull back. Just watch this fluoro as I'm pulling back there, hooking the left carotid, and then I'm going to just hold the wire.
Mm-hmm.
And then I'm going to advance the left carotid filter inside. Yeah, interesting.
I think you're in the
It
aorta
is.
still,
Yeah. But I just had to pull this back. So it's
Yeah,
actually popped in very nicely.
Yeah.
So it is a little bit calcified in the orifice, but we've got a nice position. I like that. Agree?
Pull
See,
back
we
more,
nicely.
a little bit. Yeah.
Yeah.
Okay. Towels, please, Mike.
Okay, so we've hooked it and we've got the cerebral protection device in. We believe in cases, especially older patients with calcified vessels, we feel strongly about putting it in. My technique is I first go a GR4, I take a P2 PT graphics extra support, advance it this in the aorta, and then, I didn't introduce you. We have perfusionists in the room.
Milo.
Milo, thank you very much from here. We always have cardiac perfusion in the room. That if anything happened, they're always available. Thank you for being with us. So he's done an ACT and it's about 251. So I think it's okay. Should we give some more?
I give another 1,000.
Another 1,000 more.
Just
Thank you, Milo. So now I'm going to cross the valve.
you want to make sure we don't.
Yeah, let's
interact
make
there?
sure we are not there. I think it's okay. We want to make sure we didn't sending so right. Now let's go here. Can somebody mag it to me? And then yeah, good. Can I get me the wire? Just a
We have
wire.
more heparin.
We can come back with the probe, please, Val.
Okay, sure. Probe coming back.
That's good.
Yeah, I like that, right? So we've made sure that we want to make sure that you're not going close to the filter. That's why I'm showing this step. Sometimes you get caught in the filter, so you have to be careful. What is the cusp? What is the three view?
Coplanar?
Coplanar view.
Yeah.
So I'm using a straight Terumo wire. What's it? RO7 quarter 15. Okay, and then there's a lot of flare. And let's put this up here in the middle. You want to give a test, Greg?
Sure.
So I'm trying to cross the valve with a straight Terumo wire. And sometimes, yes, test please. Okay.
Oop, I thought you had it.
Okay. So it's inside.
Keep it down in the peanut gallery, please.
Okay. So we're going right there. Okay. Good. So we advanced the AL1 catheter in, and now we're going to do a soft wire. And then, Mauro, you're going to hold this when I tell you to hold it. So we usually like to measure the gradients pre, and that's what we're doing right now. By the way, those two clips that you can see are in the tricuspid valve. No, hold the sheet. Yeah, not the catheter. Yeah. So, yeah, I like the position of the wire.
Can you turn off the...
And Greg is exchanging the wire out.
Slow it down.
Wire?
Right here.
Yep. So this is your first TAVR that you ever scrubbed in. Supposed to fill. That's great.
So you
Mala, everything's okay?
Pressure to drop. Pressure's going to drop when they pace like that. If they were pacing, I don't know if they're pacing. Thought so.
But John, thanks for being here and getting the
Or maybe she
patient so fast on the table.
I'm not sure.
I was actually quite surprised.
Okay.
I don't think they were pacing.
Sable?
Yeah, so go in. Now advance it. So we have a 14 French central sheath in the groin, and we like to use the inline sheath so that we don't have, because the mean arterial diameter is only 5.5. So we want to go sheathless in this case. So just stop there, and I just want to advance the pigtail.
Let me just move this way over there.
Okay, I like that.
Get it?
You don't have any potassium, do you?
Okay, good. Correct.
Do you have any potassium?
Now we're going to measure pressures now, pressure differences. Yeah, okay.
Here, Mila, help me for a second. You say you don't have a cart?
Okay.
We don't.
So we have the gradients. Can you show the pressure monitor, hemodynamics?
You don't have any potassium, though, do you?
Pedro, can you show the hemodynamics? Yeah.
Is he asking me something?
There we go.
What's the gradient, Kristen or Gabe?
I'll go right here. It's okay.
That's a good one. It's not very bad, huh? We got a gradient of 38 by echo transthoracic. We always like to do an accurate measurement. We also make sure the LVDP, it's 10, so that's not bad.
Especially with her AI.
Yeah. Yeah, especially she's got a lot of AI too. She's got AS and AI. Gabe? You got it?
So it's got that extra beat, but it's measuring 40.5.
40.5. Okay, so that's a lot. So the mean gradient's around 40. So I think I'm actually happy to pre-dilate. So we have an 18 balloon or something like that?
Can 18 Z-man or a 20 true? So.
I don't use a true for this. Why should we?
Yeah.
It's just small. Okay, so we are going to pre-dilate this case. It's not very heavily calcified, but I think it's okay to.
I think it's
if you want to do a
pretty heavy.
Okay, that's fine. All right, we'll do a pre. So we tend to use a double curve Lundquist wire in all cases. People don't like it very much, but this is the double curve Lundquist wire. It's a little stiff, but you have to know how to play with it. We have to be very careful, especially with older women. But I'm going to show you a safe way of doing it.
Okay.
We're going to go with this wire in, see what we're doing. I'll go right with this wire in the end.
Hello.
You see the pigtail is nicely moving stable. Hold the catheter there. And then I'm just going to make a round curl. And once we make that curl, then I just pull the wire catheter back. We've got a nice big loop. And we're not going to push the wire or pull the wire anymore.
Well,
she's helping here. So I asked Kathy, I asked you.
So the big thing is that you should not push the wire anymore. Just keep it where they are. And I think it's in a nice position. Okay, good. Hold the wire now. Yeah, that's good.
Okay, let's do a fluoro check before we do the BAV.
Now, before we do a BAV, we always try to make sure that the valve is mounted correctly. So we're doing a fluoroscopic visualization
on the lung field.
On the lung field.
Yeah.
And we're seeing that the two tabs are on the lower side.
Yeah, just throwing extra beats and.
Looks good, Carl. Do you agree?
Sort of.
Yep.
Okay,
That's
so
very
we're ready
good.
for the BAV now. Let's go ahead. Carl, you can take this from me.
So Carl's already got the 26 valve ready to go. And we are just use it there. And once we're going to go there, you hold the wire.
The
Okay.
18 Z-Med. Okay, yeah.
Yeah, I mean, if she's
What's
having
the
a lot of
what's the
ectopy,
view
we
you
call
said?
it, it's
For
basically
the
when
cusp
there's a lot
overlap or
of
the
irregular
coplanar?
heartbeats coming
We're in the
from
coplanar view right now.
Is this
succession,
coplanar?
Yep.
the blood
Is this
pressure
coplanar
is
15
like-
RL core 9? Okay. RL 7 core 15.
Because it's not a very efficient contraction of the heart. So the heart's wasting a lot of time and energy. There's no potassium in there, right? Is that what you're going?
Straight, it's a lot of resistance there.
I checked, but maybe I looked under the wrong thing.
Okay, wire.
No, advance it.
I thought so too. But
Okay. Yeah. And always look Marwa at the kick for. Yeah. Okay. Good. Okay. Good.
That's the ectopy.
Keep going. Good. Keep going.
Val, we're going to do a balloon valvuloplasty here first.
okay.
Okay. Slowly advance it. You see the dots of the balloon. Keep going. Can you see the dots? Good. Go a little bit more.
I'm seeing a
Just
lot
go a
of
little bit more.
irregularity on the
Good.
EKG.
Tiny bit more inside. Go.
Keep going.
Keep going. Keep going. More. More. A little bit more. And stop.
Those are
Stop. That's
tickling the
perfect.
heart too, you know,
Let
with
me
all
just
their catheters.
test.
Be ready for 180, please.
So
Ready at
what
180.
size balloon did we take?
18 Z-Med.
Okay, so that's not bad. We don't want to overdilate it.
Yeah.
So pacing ready? Okay,
The rapid
pacing
pacing
on.
Drop the blood pressure fairly low.
Okay,
Capturing
go.
going up.
It's
Good.
just temporary.
And deflate and stop pacing.
Okay, like flat lines are.
Okay,
That's the
pressure is
pacing.
coming back.
Okay. Mike, grab this, please.
There's probably a lot of AI. You want to see the?
Fluoro, please.
Okay. Be careful of the wire there.
Okay. You have wire?
Yeah. Yes. Don't want to lose that wire
The murmur
position.
is
Good.
secondary
I like
to
that.
the tightness of the aortic valve.
You just want to
It's
see an echo and see if the
systolic
AI got worse. The pressure is better. If you can get a little bit more on the pressure, we would like it.
murmur. Okay.
I think without the
It's
ectopy,
actually
she's
not
good.
bad.
She's good without the ectopy.
It's actually quite good.
Yeah.
Okay.
Yeah, good. So we like to make sure that the pressure is good before we start manipulating the valve now. And with this,
What-
basically, I think we should go ahead.
Sure.
And
You want to look at the echo one more time?
no, it's okay.
It's okay.
It's okay.
All right.
Got a pretty good
Alright.
pulse pressure even at this.
Yeah, it's actually
so-
quite good.
Yeah.
So now you're going to hold pressure with two fingers like that, two in the top, hard and nice and tight. And I'm going to kick this
I can
sheath
do it
out.
here, Kathy.
And then Greg's going to take over from me.
Thank you, sweetie.
Good, I'm holding the
Good
wire.
wire.
Give me something to clean the wire.
Got to work out.
So we're going in line.
Yeah, she did.
As you can see, we removed the 14 French sheath in, and we should go in line. I think the FX, Greg, you agree, has made things much more easier, especially with these borderline vascular
Yeah,
anatomy
at
cases.
all levels, and the vessel entry is better. It's much more flexible in difficult anatomies.
Yes, of
It's not
course.
very much potassium,
I have the wire.
but
Okay, good.
I
Then
just
you can let
didn't-
your
And
hand go.
as you notice, she had that
Give her a
distal
little
aortic
bit of
disease,
it.
so
Okay, you can advance it slowly. Go.
is a little happier.
You see
with
it feeling
that.
smooth? Let the wire go a little
No, I
bit.
was just pushing
Yeah.
it in. It's just a
Go
chamber
more.
that
Go
allows
right
me
inside.
to pressurize the
Good.
what's going
Yeah,
All
on.
right.
It's going
easily.
inside.
Perfect. So now what we'll do is
Just 10
we're going to go to LAO view.
cues.
And the reason why we're going LAO is to make sure we are, come this close.
Yeah,
It's right in front of you. Come closer to me.
it's actually not that much.
So we're going to LAO.
a little higher.
And yeah. Now advance your catheter.
I mean, how would you know 10
Okay,
is a
keep
lot or
going.
little? I mean, you
Go.
don't know, but
Go a little bit faster.
in our experience, it's like, you know,
Keep going.
you're
Faster.
Oh,
Go, yeah.
you're usually giving
Yeah,
us 20.
it's not going in? Okay.
You know, to
Good.
make a change. This
Okay, so it's in the outer 1/3. That looks
The
great.
the hat markers on the outer
Yeah,
one.
just
That's
so we
trying
can
to
go.
make it work.
going.
Go.
Traversing the arch now.
Don't pull the wire. Let the wire go. Go. Okay. That's really
Just trying to take
nice.
some medication, you know, and
That's really
nutritional
nice. And go a little bit
medication,
more.
just The precision
tiny bit
is
more.
for hyperventilating
And
her
stop
and things
there.
like that.
Okay,
It
let's go to
changes
cusp
the
overlap view.
chemistry and the pH of the blood, and it causes
Okay, so we're going to need to get
transcellular
the near, please.
changes,
The
and
near.
the potassium is hanging out.
So we're
It's a
using the
temporary
near
change.
cusp overlap view because the angles were too sharp. So the 26, 27, yes, good.
It can also happen for various reasons, but
And then decrease the REO. Okay, good.
I'm sorry, 26 and
That's not bad.
yeah, wait until they pace again.
Actually, that's actually quite good. So what I'll do, Greg, is I'll just
do it.
advance it a little bit,
This was
and then I'm just going to move this pigtail out because it's wrapped
it's got a
around it.
little
I
in
don't
there.
like
Look,
that.
it's got a little gauge right here.
And now it's in a better position. Okay, how do I get the lung field to be out? It's so, okay. Should magnify that. That's better, right? Now your
I think
test.
the wires, okay.
Wires come out a little bit. Okay, good. That looks really nice, huh? So the position you see is in the non-coronary cusp, and now I'm going to go slightly in, and I'll just, you see that? I'm just below there, and let's take one image there. Okay, you see that there's a pigtail. We want to be in the little bit bottom of the pigtail, Cindy. Okay, good.
I'm going to start towards the bottom of the pigtail.
Can I see the last picture? So there is, it's a little bit lower than that. Not that I can go any further.
Yeah, there you go. That's good. One more test there to see.
No, actually.
Well, no, you
when
just did it
no.
came back on itself. Okay.
Okay. I think that's the best we can do.
Yeah.
Okay. So I'm just going to go a little bit below here. I'm going to start from here, right? Okay, good.
I think you're a bit high. You're high.
And Mike, you want to test? So we have to be a couple of millimeters below.
Right about 0 there.
Yeah, right.
Those dots are
Now,
3
this is good.
millimeters from the
Yeah.
end of the stent. So
we can stop here and see what's going on. Just test.
yeah,
Yes.
you can be ready at 140 on
I
the
think
pacing.
this is good. Let's do a short cine.
It's pretty good.
No, Mike. I need a hard injection. Small, short, hard. No, I need a hard, proper injection. Good.
Perfect. That's perfect.
Looks very nice.
Okay, we can start pacing at 140, please.
Okay. See, as we flare up, then we start to deploy, and I'm just focusing that the valve is not moving up or down. Small test, Mike. That's very good. And a hard one. Hard, Mike. Very nice. Good.
You can see how stable the
Valve
VFX
is.
is just much more stable.
Good.
Okay, come down by 10s on the pacing.
So he's coming slowly down at 10. We'll do one short cine. This looks really good. And now let's do LAO a little bit.
Sorry.
Oh, wait a second.
It's okay. I'm coming away from them.
Okay, good.
Parallax.
Just go
About
more
there?
LAO. It takes the parallax off. Just go more LAO.
Okay.
Okay, good. That will help you. Okay.
And
All
center
right.
that a bit.
Cine.
1 second. Let me get. Okay. I'm ready now.
Okay, good. So it's
Covered both sides.
right. So it's covered both sides. I'm happy with the distance, and I'm happy to deploy in this angle.
Yeah.
Okay. So you can see coronary. So let's go. Okay. So we're going to deploy now. So Mike, give me a test when you're ready. The valve is expanding. Test a little bit more. Okay.
Both off.
Okay, both are off. So okay, just
Slowly.
pulling this thing, now pushing the wire back again.
Yeah.
As he's pushing the wire in, now you can push the wire in.
Yeah.
And you also have to be careful in the last step is to make sure that it doesn't hook on anything. So you push. Okay, that's great. So we got it out.
Okay.
And once you go here,
Sheets ready.
now I'm just going to be on a, see that angle? Okay, good. And now I would
Ready?
advance the wire a little bit.
Yeah.
Correct? Okay, and now he's going to recapture it.
Right here. Can you show me?
Right? Yeah.
Show me the. Can't
Top.
see the whole thing.
Okay.
Okay. There we go.
Good.
Watch the
Good.
wire.
So you're recapturing the valve. Okay, good. Okay, let's go. Let's go.
Okay.
Ready?
Coming.
And then you're going to hold pressure when I tell you to. Good. Okay,
Okay,
good.
you got it?
Yeah,
You got
good.
it?
Hold pressure there. Nice and hard. Good. So we've taken it out. Now we're just going to put the sheath back in. Pressure looks okay. Maybe you should do a T now. Start getting ready for T. So the valve is deployed. I think our deployment is good. There's no heart block or anything like that. That's good. We're going to put the 14 French sheath back again. Okay, good. Now let's get a big.
Watch the wire.
Yeah. Hold the sheath. Hold the sheath. Hold the sheath with the hand. Okay.
Got
Good.
it? Got
So
it?
it's a little bit lower than we wanted, but it's not bad. There doesn't seem much of AI, but let me see. Right? So can we show T large, please? Wait a second. I want them to see a.
if you look at the depth, maybe we're just at the bottom of the sinus
Yeah,
section. I
sinus,
think
yeah.
we're not as deep as you think. That looks good. Yeah.
So
Okay.
can you show echo large? Yes, that's good. Make the echo the large one. Very good. That looks beautiful
The wire.
pictures.
Sidewalls. Wire.
Very, yes, sorry. Go ahead. Go. And yeah. So we're going to. I don't see much of a leakage, and I'd like you to see in other views. I don't see the leakage here too either, right? Keep go faster.
Looks great. Needs a mitral clip now, though.
Okay, that's good. Good. All right, that's enough. You see the pigtail there?
Yeah.
Yeah. Always tend to look there. Don't
Okay.
look at your hands. Okay, so I'm going to flush this side port. And give me a, can I get a wire? I'm going to pull the other catheter back. The pressure is really up now. Did you do anything? Yeah, now our blood pressure is really up. And that looks, I don't see any AI at all
No.
by echo. I'm actually quite impressed. Valerie, I'm very impressed by your imaging. Do you want me to help you do the anesthesia?
Okay. Mike?
The zero's okay? So we want to make sure that the other pigtail is above the, just above the valve. There. All right, so let's get a gradient. It's like zero. There's actually no gradient. Can you show the hemo well?
Nice dichrotic notch on the...
Pedro, show hemo, please. I think we're done over here.
Yeah. So maybe we should talk a little bit about why we chose this valve in this patient.
Yeah. What do you think?
Yeah, I mean, this is...
So can you measure the gradient once? And then we just talk.
Both.
How much do you get, Gabe?
2.8. Not 2.9,
2.8.
not 2.7, but 2.8.
That's really nice, eh? This is really. So let's do a pullback. Ready for pullback? Yeah, just pull the catheter back. Just pull it back and look there. Always look there. Good. Let's stay. Let's stop there. Good. All right. So I think it's 2.8. I don't see any. We didn't get any gradients. Only 2.8. We don't need to do a gradient, Valerie. So Valerie, before do you want to show us the AI? Right. So you did deep transgastric, and then I'm going to ask what's a comment from Greg. So we don't see any AI. We like the position of the valve. You did a 3D. You did an X-plane of that, right? And in the X-plane, you see it's quite a circular valve, right? So I don't see any gradient. So can you be ready for an angiogram? Just 15 cc total. So Greg, you want to make a comment of why we chose this valve?
Well, over the years, I think we've had the pleasure of watching this field grow, and one of the things that's most exciting to me as a surgeon is we're talking a lot about hemodynamics, and we know from surgical valve that hemodynamics predict durability and also affect mortality. So when you get into especially in small patients like this, having a valve that can give you 2 millimeter gradients at the end.
What was the annular area in this one? John, that's a TAVR, John.
So suffice it to say, there's no surgical valve we could put in that would give you a 2 millimeter gradient at the end of the procedure, unless you massively enlarge the root in this little patient. So, so we love the hemodynamics, and so far it appears to portend.
Because otherwise we
durability.
would have to use a 23
23
sapien valve. Yeah.
375 is the.
Yeah, so that's actually quite low. Anything greater than anything less than 430. So this is a good case, and there's a whole trial on this, trying to show this, and this is very beautiful to show that we got a gradient of less than.
The extension on sidewalk.
We need an extension? No, it's okay. I can do without it.
Okay. Good for you.
Yeah.
We have to bring the catheter.
Can you?
Bring this down. You got more. Here. Mm-hmm. Yep, there's air. There's air. Come back.
Okay, so we're doing the final picture, and you're doing 15 cc only, right?
Mm-hmm.
Good.
If you can come back just to 2 inches, Val,
We're just going to do one angiogram.
And then we're done. And then you'll check for the usual fusion, etc. Okay, thank you.
You see the valve position there? And then we just go a little bit down. Ready, go? 15 at 15.
Ready? Okay. Go ahead, Saibo, you push
Ready?
the button. Mm-hmm.
Should I go?
Yep.
Inject, please.
Beautiful.
Yeah, there's no AI at all.
Yeah.
And the depth looks good.
Yeah, perfect.
And both coronaries are actually flowing very well. You see the coronary coming off? So it actually was very nice. And you can see the white leaflet there at the border. So it's actually great. So I think we're done over here. I think this was a good example to show the advantage of using an Evolut, a self-expanding valve in a small annuli.
Yeah, exactly. She had a lot of AI. That probably is the reason why she's so symptomatic. Maybe her gradient wasn't super high, but she had at least moderate, if not more,
out. So you
aortic
can take
regurgitation.
this out
So
and pull the pacing wire out. Pull it
should
out.
feel better.
Yeah. And just on the floor again. Look at this.
I'll
Put it
coming
out.
around.
Yep.
So what about protamine? Cybele?
So while we're doing the groin, I want you to show. Can you show echo large? And I want you to show the tricuspid in the clip of the tricuspid.
Are we ready for protamine yet?
We are.
Yeah, we are ready. Okay.
Yeah, the light up here,
Get the
Mike.
wire.
Pacemaker wires out. So we had no change in conduction.
No, don't get the protamine yet. Just hold a second.
No, we have to
The key is that we got to take the sentinel protection device. That's key.
Yeah.
So we want to show that. Can you show fluoro once how we're taking out the sentinel? No, don't get fluoro yet.
No protamine until this is out.
Fluoro large. Okay. So you pull 3 back. Recapture that. And then
just
pull the wire back inside.
Yeah. Mm-hmm.
Then I push 2 in, and then I open the flexion and go right inside. Then push the wire out. Now I'm going to recapture 1. Let your hand go in this one. Good.
There you go.
And now I just hold the sheath.
Okay, now we can get protamine.
Okay.
Sure.
So now what we're going to do is we're going to take care of this groin. So you can be ready for protamine.
Yeah,
and Valerie, you should take a
I am.
do fluoro small and do echo large so that she can show some images of the tricuspid.
Panvalvular. Yeah.
You think so? You think this is all rheumatic?
Well, that's what's in the record. I wasn't sure.
I'm not sure.
Well, maybe true and unrelated, but
the tricuspid clips doesn't work in rheumatic valves.
Well, that may be secondary to left-sided valvular lesion. So, yeah.
It's a nice result. Okay. Yeah. So we're putting a mammary catheter from the left side so we can do up and over injection once we come out to make sure we have not done any harm to the vessel. And that's what I'm trying to do now. I'm just trying to do a up and over the iliac artery. Good. I think that should be
I think
okay.
that's good. Want to take a test?
Yep, that's beautiful. No, you don't need to test. It's okay. So you're ready to go? So we put the mammary from the left groin. Now what we're doing is we're going to put a wire on the right side. Now you can start showing how we take the... I want you to go on large on the patient so that we can see how we deal with it. That's okay. No problem. I'll take this out and then I'll...
Got the dilator ready, please?
Okay. So we always put the dilator in holder sheath. Okay. So you don't want the sheath to come out. Now give me the dilator. You've given some protamine to the patient.
Thank you.
Okay, so we put the sheath on the dilator. We always come to Samara. This side, yeah. Okay.
Got a little tachycardic. What is that from?
It's okay. Yeah. So what I'm doing is, I'm going to get this bunch holder. So I'm going to put this in.
Okay, so we're going to withdraw with the dilator in place over the wire, the soft wire, not the stiff wire, and sequentially deploy the
Two
perclose.
percloses, okay, good.
I just keep a little pressure here so we have a clean field.
Good.
And Cybel's down.
Yeah. Okay.
See a sponge, please?
So can I get a 4x4? And he's pulling the two knots together. So I wouldn't go more tighter than that. Okay, good.
Okay, come on.
One, two. So he's locking it up, and then he's going to. Good. And now I'm going to push this knot down. See, it's already stopped quite a lot. It's actually quite good. It's really nice, huh? I think just two percloses made a nice difference. I would actually go for a 6 French angioseal.
She's got a small vessel. I think
So you don't want it in.
And then let's just take this out a bit. I bet she's fine.
Let me just see how it is. Just let your hand go. What I'm going to do, Greg, since you are saying that, which I think is not unreasonable. 6 French is not too bad, though. But if you think it's, why don't we let's do an angiogram, right? Let's look at what it looks like. Mike, do you want to do a picture?
I got it.
Just give a test, Greg, sir. Good. It looks really nice. See that? Looks really good, huh? There's a little bit of a contrast flowing out. You see that? So we can hold pressure, or we can just put a small seal. It looks very good.
I'm fine either way.
Yeah. It looks very nice, actually.
Like nothing going on here. I think a minute of holding once the wire's out, I don't think you'll be fine.
Okay. All right. So we're going to pull this. It looks very good. We're just going to pull the wire out, and we're just going to hold pressure.
Very little, very little.
Okay.
The wire's out. There you go.
And can I get? So we actually like this very much, Mike. You hold pressure, and on the other side, just put a 6 French angioseal in. So I'm just tightening the knot again, swing it a little bit more. Pressure is really good in the patient now, 121. I want to tighten this up. And, oh man.
Oh.
Just the time when we wanted to. Yeah.
Okay. I think we'll be able. Did you go down with this one, though?
I did.
That's true.
Just tighten it up. I did. The suture may have given away. Always like to do that violent shot.
I used to have a hard time convincing you, and then you've become now loving it.
6 French angiocerotomy,
Yeah.
but I only use 6 French.
Yeah.
Okay, that's good.
No
That's
sponge,
okay.
please. To John.
John, you take over? Okay.
He's
So we're
an
just going to
expert.
hold some pressure. On behalf of all the staff, I'd like to thank you, everybody. This was a case where we used a 26 Evolut in a patient with a small annuli. We got a great result. We used the cusp overlap technique. We've had no vascular or major issues at all. We used the Sentinel protection device, and I think it worked very well. And I want to thank all the staff members, everybody in the room and outside the room, and the whole anesthesia team and the perfusionist team. Thank you very much for participating. Valerie, thank you.
Thank you very much. Sophia?